Hello and welcome to today's Center for Healthcare Strategies webinar, made possible by the California Healthcare Foundation and Blue Shield of California Foundation on accelerating value-based payment in federally qualified health centers, options for Medicaid health plans. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be question and answer sessions following each presentation. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Greg Howe, Senior Program Officer at the Center for Healthcare Strategy.
Thanks, Travis. Good afternoon, everyone. As Travis said, my name is Greg Howe, and I am a Senior Program Officer at CHCS. I'd like to again thank the California Healthcare Foundation and Blue Shield of California Foundation for their support for this webinar. We're particularly grateful to Catherine Phillips at the California Healthcare Foundation and Richard Thomason at the Blue Shield of California Foundation. For those of you who are not familiar with CHCS, we are a nonprofit policy center dedicated to improving the health of low-income Americans. CHCS was established in 1995 through a major grant from the Robert Wood Johnson Foundation to improve the underpinnings of the nation's healthcare safety net. Today, our mission is to support innovations in care delivery and improve the health of low-income Americans, particularly individuals with complex and high-cost needs. To achieve its mission, we work with states, health plans, providers, community-based organizations, and federal policymakers, focusing on three priorities: integrating services for people with complex needs, advancing delivery system and payment reform, and building Medicaid and cross-sector leadership capacity. Our activities fall under the broad buckets of knowledge development, collaborative learning, technical assistance, and best practice dissemination. The purpose of today's webinar is to highlight a few examples of promising value-based payment approaches for FQHCs and Medicaid health plans. The VBP models featured are designed to give FQHCs more flexibility in delivering patient-centered care and the ability to obtain financial incentives for improving quality and reducing costs across the larger healthcare system. I'll lead off the presentations with an overview of the findings from our April 2019 report, Accelerating Value-Based Payment in California's Federally Qualified Health Centers, Options for Medicaid Health Plans. You'll then hear about a successful partnership in Colorado between Rocky Mountain Health Plans and the Mountain Family Health Center, followed by a presentation on a recently launched VBP model by the Inland Empire Health Plan from California. We'll finish up the webinar with a moderated discussion with our speakers, where they will also answer questions that you all submit during the webinar. Here are our speakers today. I will introduce them in more detail prior to their presentations. You will be hearing from Patrick Gordon, Chief Executive Officer, Rocky Mountain Health Plans, Art Fernandez, Chief Operating Officer, Mountain Family Health Center in Colorado, Kirk Hubler, Chief Network Officer, Inland Empire Health Plan of California, and my colleague Tricia McGinnis will be moderating the discussion at the end. Tricia is Executive Vice President and Chief Program Officer here at CHCS. I also want to acknowledge another CHCS colleague who is not pictured here, and that's Rob Houston, Director of Payment Reform, who helped with the development of this webinar. This past April, CHCS released a report, Accelerating VBP in California's FQHCs, Options for Medicaid Health Plans, which is available from our website. Like this webinar, the report was funded by the California Healthcare Foundation and Blue Shield of California Foundation. It focuses on how MCOs and FQHCs can form innovative and mutually beneficial VBP arrangements, and it explores examples from across the country and in California. Over the next few minutes, I'm going to pull out some highlights from the report to help tee up and frame today's presentations, which are examples of health plan and FQHC VBP models. When we refer to value-based payment, we are referring to a broad set of performance-based payment strategies that link financial incentives to providers' performance on a set of defined measures of quality and/or cost or resource use. The goals of VBP are to improve quality of care and health outcomes, lower the costs, and improve the patient's experience of the healthcare system. Many FQHCs are participating in VBP programs, particularly health plan-led pay-for-performance programs. In our report, we attempt to move beyond pay-for-performance initiatives and focus on the ability of plans and providers to impact care across the healthcare spectrum by moving from incentive programs that focus on an FQHC's own quality to new payment models that impact the quality and cost of care patients receive beyond the FQHC walls. This approach to VBP aligns with the commercial market, and for those entities who implement VBP, it can be a competitive advantage. In this space, there are opportunities for partnerships between health plans and FQHCs that do not require state or federal approval. Specifically, for MCOs, there's an opportunity for better quality and reduced costs, a greater provider stake in cost management, and finally, VBP creates a greater alignment between provider-led and plan-level functions. For FQHCs, with VBP, there's an opportunity for greater flexibility on the type of services provided and the ability to provide services beyond the traditional scope. There's a greater ability to exercise control on care management through access to better data and opportunities to earn bonuses and incentives to support those activities. In the report, we look at payment models that can help move along the continuum toward greater FQHC integration and accountability. I'm not going to get into the details of those models today, but wanted to do some quick level setting by briefly mentioning 4 of the most common VBP approaches. First, pay for performance, which ties provider payment directly to specific indicators of quality or efficiency. 2, bundle payments, which involves a bundle payment for a set of services that occur over time and across settings. 3, in shared savings risk arrangements, providers that succeed in keeping costs below a total cost of care benchmark keep a percentage of the savings, and you'll hear an example of this model later. For capitation and global payments, providers receive an upfront per member per month payment to cover a wide range of services. In the report, we also address the challenges of implementing VBP in FQHCs. For this presentation, I wanted to quickly highlight a few of those capabilities that FQHCs need in order to be successful in VBP. Those include being able to implement care models to manage complex patients, using data to support care delivery, improve quality, and reduce total cost of care, coordinating effectively with external providers and community-based organizations, and building internal and external support for these efforts. This involves tracking patients' outcomes and costs, potentially significant startup costs, and changing business as usual. One of the obvious challenges for FQHC VBP models is dealing with the rules around the Prospective Payment System, or PPS. In Medicaid, federal law requires that FQHCs be reimbursed for all reasonable costs associated with the services they provide through PPS or through an alternative payment methodology based on the health center's historical costs of providing comprehensive care to Medicaid patients. Each FQHC has its own PPS or APM rate. If a state chooses to reimburse health centers via an APM, 2 statutory requirements must be met. First, each health center must agree to the APM, and second, that any payment be no less than what a health center would have received through the PPS rate. The latter provision has historically limited the types of VBP arrangements that states and plans can enter into with the FQHCs, such as those involving downside risk, as direct payments to FQHCs cannot decrease under a VBP arrangement. So what are the options then for MCO FQHC contracts? FQHCs can contract with MCOs via upside-only VBP arrangements without concern for PPS restrictions, meaning that they can be designed to meet federal PPS equivalency requirements. They can be through pay-for-performance, bundle payments, shared savings, or risk-based capitation. However, there are 3 ways that FQHCs can participate in VBP arrangements with downside risk. This can happen in VBP programs involving services not covered under PPS rates. MCOs could pay FQHCs rates above PPS and put that portion at risk. Or FQHCs could join in VBP arrangements with organizations that are capable of taking on risk. Also in the report, we provide an overview of state-based VBP programs for FQHCs. There are basically three versions of state-led VBP models for FQHCs: capitated APMs, quality rate adjustments, and Medicaid ACO shared savings programs. There are two states that have implemented capitated APMs, Oregon and Washington. Colorado is also working on one. They pay rates above PPS and then put that portion at risk. In Arizona, FQHCs can earn a 0.5% increase on the PPS rate for each of 3 clinical quality measures it meets, which is up to a 1.5% total increase. Finally, FQHC-led Medicaid ACOs participate in shared savings programs in Massachusetts, Maine, Minnesota, and Rhode Island. In the report, we look at the Community Care Cooperative in Massachusetts, which formed as an ACO in the state's ACO program. There are 17 FQHCs in that program. In Minnesota, the FQHC Urban Health Network includes 10 FQHCs over 40 sites that participate in the state's ACO program. So turning to a few local and regional examples, these are models that can be put in place without state or federal approval. In the report, we highlight the Accountable Healthcare Alliance of Rural Oahu in Hawaii and the Medical Home Network ACO in Illinois. We also describe the Rocky model and IEHP's program, and you'll hear directly from them in a few minutes. So there are a few common themes that we found in all of these models, and some of these you'll hear in the presentations that follow. First, there's an alignment of mission and goals between the partners. There's trust and transparency among partners are key ingredients, along with good communication in all aspects. There's a defined governance structure, typically where there's equity between the partners. Strong delivery systems and strong data infrastructure are critical. Knowing who the other entities in the system are and building those relationships is important. And to be successful, you need buy-in from everyone in the organization. So we're now going to turn to our first presenters, Patrick Gordon and Art Fernandez. They're going to share an example of a VBP model in operation in Colorado. So in addition to talking about the details of the model itself, they will highlight each of their organization's motivation to develop a partnership. They will highlight key elements that make their partnership successful. They're going to discuss how they have involved the community, and they'll identify barriers, challenges, and how they're being addressed. Patrick Gordon is the Chief Executive Officer for the Rocky Mountain Health Plans based in Colorado, which is a United Healthcare company. Patrick previously served as the Vice President of the Rocky Mountain Health Plans, where he led the implementation of a wide array of practice transformation, payment reform, and technology innovations, including the statutory Medicaid payment reform for Medicaid enrollees, the PRIME initiative, which he'll talk about today. Patrick also procured and led coalition development for the social risk factor screening and clinical sites, community navigation for patients with complex needs, and social information exchange. Art Fernandez is Chief Operating Officer for Mountain Family Health Centers, which is an FQHC system in western Colorado. Mountain Family Health Centers provides integrated primary medical, behavioral, and dental health care to more than 21,000 persons at 8 clinic sites located in 4 counties. As Chief Operating Officer, Art is responsible for Mountain Family's organizational operations. He leads medical and dental operations, school-based health centers, Title X family planning, information technology, quality assurance, risk management, and compliance. Prior to joining Mountain Family in 2007, Art worked for several Southern California for-profit and nonprofit medical and dental organizations, as well as in banking operations with Bank of America. So I'm going to turn it over to Patrick and Art.
Good morning. Thank you, Greg, and thank you, Art, for joining me today to share our work. We're going to take about 10 or 15 minutes and give you an overview of the program we have operating in western Colorado. We've got about 5 years under our belt at this point, and a lot of lessons learned the hard way. So hopefully this will be valuable to you. Just very quickly, a thumbnail of who and where we are. Again, I'm with Rocky Mountain Health Plans, and we operate a Medicaid health plan, which covers about 190,000 people, all told, from Medicaid and CHIP. We also deliver the Medicaid behavioral health benefit, to about 180,000 of those folks across 22 counties. Incredible geographic spread. We've got rural and frontier counties, but also some pretty urban counties within our mix, and so a lot of diversity. I think the thing that's important is that we've really tried to organize our work at the local level as much as possible. That's a necessity given our geography, and have just sort of followed natural breakdowns in leadership. We also really have aligned significantly with FQHC and community mental health center catchments, public health catchments, public health data reporting in the state, and so that has served us well. We've also aligned closely with several key federal programs. They have really helped our cause over the last 5, 6, 7 years, everything from the Comprehensive Primary Care Plus initiative, the SIM initiative, the current Accountable Health Communities Model initiative, which is a social determinant program from CMS, and of course, CMS DSNP. I think the key also, though, is that across this region, and really pertinent today, is that we have partnered very closely in a joint effort, a very focused and structured effort with all but one of the FQHCs and all but one of the community mental health centers through what we call a joint operating agreement. And in a nutshell, everything Greg said is true. You've got to have transparency, you've got to have data, you've got to have trust and strong leadership. But you also have to have structure and time invested. I spend at least 2 hours a week, whether I need it or not, with appointed CEO representatives from the FQs and mental health centers in our region, and we hold each other accountable. Our goal is to drive all facets of integration. You really can't do an APM unless you have all of these other pieces in place. That includes clinical transformation, as well as the financial component. But central to that is leadership and an aligned leadership culture, and that's something we work very intentionally to promote every week, in and out. We also have a couple of core values, which is that, this isn't an exclusive arrangement. This isn't an arrangement with one group but not the other. There's significant participation by private providers in our network, and we treat them all the same. Whether you're hospital-owned, small independent practice, large multi-specialty group, FQ or RHC, community mental health center, or independent behavioral health, we all play by the same rules, and that starts with the principle of transparency, an inclusive approach to our network, inclusive and structured, and that structure is really based upon demonstrated performance and the opportunity to improve over time. To that end, on the primary care front, we have very intentionally adopted Thomas Bodenheimer's work to really give form and structure to our practice transformation programs and to our network tiering. And in essence, without getting into the weeds, we start with a very basic level of participation down at the bottom of the pyramid, which is really foundational, learning basic quality improvement competencies, data use competencies, and work our way up the chart, so to speak, in terms of empanelment, care management, risk stratification, and then, of course, integration of behavioral health and social determinant programs. We've worked on this for many, many years. We just, over the course of the last 2 years, were able to actually get to a place where we could clearly articulate what the criteria are for each tier and clearly articulate what the benefits are of participating in each tier. And so that very much drives our APM programs and resource sharing. In a nutshell, in terms of provider commitments, there's two things: one, structure and quality, and then commitment to Medicaid. When we're talking about our Medicaid program, our investments and our dollars need to go to the providers that are serving the population. And so we've put in very intentional, flexible but intentional Medicaid access commitments, which of course FQHCs routinely fill, but also pretty rigorous quality and structure commitments. And ultimately, if you think about the Bodenheimer model and you think about this tiering structure, you work your way up from basic engagement in the program and in the network, really just for access and continuity, all the way up to mastery. where practices and the plan work together closely as partners and really sponsor a host of behavioral health and social determinant use cases. The good news for us, a little bit more than a year into this formal structure, is that our attribution breaks nicely across the tiers, across our network. Without, again, getting too far in the weeds, we've got roughly 40% of the practices shown in the blue bars in tiers 1 and 2, the top 2 tiers, really demonstrating advanced competencies and mastery and commitment to access for the Medicaid population. And they serve over 60% of our membership. And so that's a good thing. We hope to continue to push membership towards those practices, and also for the groups in the lower 2 tiers. Again, one of our values is inclusion. We want to afford them every opportunity to move up the scale in our tiering program. When it comes to payment, there's several features to this. I could take a week, or at least I could, because I enjoy this topic, to talk about it. One of the things that we have worked on is to really link our model to attribution. And attribution, as opposed to assignment, attribution as a reflection of current active treating relationship, whether it's evidence in claims and encounters or in self-reported, mutually recognized relationships between primary care practices and members. And so, in essence, we create an incentive through our APMs because they are significantly enhanced over straight fee schedules and certainly over straight Medicaid. For growing attribution, we want to achieve the highest possible attribution rates, highest active pattern of care rates we can for our top tier practices in the program. Really, when it comes to the payment model, we focus on E&M services and of course for FQs, everything that's pretty much carved into the physical health encounters. Our model is that our payments, our PMPMs, they're capitated, not meaning a transfer of risk inappropriately to primary care practices, but capitated in terms of the form of payment so that they're not volume-based. They are risk-adjusted and enhanced. And of course, as you work your way up the tiers, the enhancements are more significant. Likewise, when it comes to incentives and shared savings, they're more significant for the higher tiers. The way it works is pretty simple. We look at our plan performance and report it quarterly in excruciating, transparent detail. We net out what the plan's operating and margin requirements are in transparency and detail. And anything that's left between those costs, benefit and operating, and the medical loss ratio floor set by the state, which is at its lowest point, 85 for Medicaid, is set up for shared savings. One thing about the state, though, is that they don't just simply allow us to claim cost savings and pass them out the door. They increase our MLR floor for every quality goal that we miss. So in essence, we've got about 4 or 5 quality objectives each contract year. And if we miss one of them, even by a hair, our MLR floor increases. It will go from 85 to 86 or 86 to 87 or whatever it is. And that reduces both the opportunity for the plan and for the providers participating in the model. So there's very direct alignment, both in terms of the measures that are selected, reported by the plan and the practices, and quality performance on the incentives that are available each year. Beyond that, we put a bunch of enhancements in place. Really, we have a separate dedicated program for integrated behavioral health and primary care, really reserved for our Tier 1 practices that have achieved mastery over several of the integration concepts. But that's a very meaningful resource and a huge incentive for FQs and private practices alike to work themselves up the tiering structure. Colorado runs a large PCCM program. We pass through a significant amount of those dollars on a tiered basis. We make health plan funded supports available. Currently, our community health worker program is actually operated by the community mental health centers. at arm's length from the health plan. We want to promote integration with the community mental health centers, and we don't just simply put workers out there, but we have a very structured approach to how community health workers are assigned to practices and how practices assign patients to that resource, measure performance as we go. And then we share a tremendous amount of technology and data across the region with our partners, and I'll get into that in a bit. On the mental health center side, again, the context here is that the state effectively, from an administrative standpoint, ended the Medicaid carve-out about a year and a half ago. Mental health centers had to make a significant shift just in terms of their orientation, culture, and kind of just overall operation to a model that is different. But we were able to use a risk-sharing arrangement to preserve all of what was good in the former carve-out program. There's a greater degree of granularity in productivity and encounter reporting and kind of accountability for performance. But they continue to share a large portion of inpatient risk for behavioral health, outpatient risk. And we as a plan pass through a significant amount of incentives when state targets are achieved. State runs 105% of premium CMS model for behavioral health, and that's a significant opportunity for the behavioral health providers. We try to walk the talk of integration, so we at Rocky perform as many of the behavioral health management functions we can ourselves, whether it's the clinical component or just the administrative component with admin and claims processing. We found that that's critical to actually making the model work. And then we take advantage of health information exchange, real-time ADT alerts, which are very well developed, fortunately in Colorado, statewide at this point, as well as integrated functions with our risk-sharing partners. And this is just a quick note to show there's a wide range of folks who currently participate online outside our walls in our care management and utilization management programs. Hospitals, community mental health centers, FQHCs, and even public health and community health alliances, all within appropriate structure and boundaries, participate in care coordination, share information, and work towards the collective good. And all of these organizations, really with the exception of the hospitals and the non-primary care groups, are part of the governance structure. Hospitals participate through a broader structure beyond primary care and behavioral health, but all in all, it's pretty well communicated and coordinated. Okay, stratification, of course, is key. Focusing where we spend our time and resources is key. We've adopted the convention of the four-quadrant model across behavioral health and physical health. What you see here is the typical distribution you might expect for adults and kids across our different products. Small number of people in the purple and the kind of orange segments driving a large share of spend. These patterns are what you would expect to see, but we really expect our top tier partners to be able to use data and use our technology and tools and partner with us to make the most of the APM investments that we put on the table. That entails a tremendous amount of data production. As Greg mentioned, we really have worked to walk the talk. We produce as much data as we can robustly every month and every quarter. Rolled right up to plan performance against state targets, routine provider or practice-specific KPIs, utilization, and total cost. And we share a fair amount of raw data with folks, eligibility, spend by category service. You know, in some cases, practices have limited resources. We need to create a lot of the business intelligence ourselves, which we do. In other cases, practices have advanced tools. They just want the data and they want to incorporate it in their own programs, registries, and structures, and we make that possible by sending a data dictionary and pretty granular raw data every month. Here's what that looks like in practice. Again, kind of a summary. We will actively show how many folks are either attributed or assigned but not attributed. That's kind of a measure of potential growth and also leakage outside of the system, so to speak. comparative risk scores, and total cost over the last 12 months across different categories of service for the provider. But the real key is granular, patient-specific, drillable data. We apply risk adjusters and a tremendous amount of cost and utilization data at the level, not just of TINs and groups, but practitioners to the extent we can, and allow providers to really click in and see what's going on and use our rankings if they choose to focus their work. We really try to focus our efforts around goals, not being sort of prescriptive about techniques or specific measures, but all in all, if the practice is making use of our data and making progress, we see that very visibly and we report it out. And that's kind of the last point here, which is that we produce run charts every month for all of our providers, including FQHCs, and across a series of basic metrics like ER performance, IP performance, and total cost. And what you see here is kind of a raw and risk normalized comparison of performance in those different domains for one of our centers, represented by our friend Art, on these metrics. All in all, what this shows is that both on a raw and a risk adjusted basis, this practice is performing very well, below the average and below our benchmark on pretty much every measure. That's an indication of the success of what we're doing. And so to the extent we get this type of performance, we have a business case for continuing our investment in the APM. Likewise, though, if a center is got a more complex population, this is just a more urban center. In some cases, the raw total cost or utilization will be higher, but we can see the value they're adding on a normalized basis. And I can't overstate the importance of risk adjustment and coding. It's an unfortunate necessity, but very central to our reporting. And this is a very high performing center showing that they're taking a complex population and bringing it back to baseline. And then likewise, from an accountability standpoint, when somebody is underperforming, that's readily available as well. This does affect shared savings because we apply a total cost performance factor in how we calculate what's available. But really, what this fosters is learning, shared accountability. This is not, good guy, bad guy, you're in or out of the network. This is really an opportunity to engage leadership on improvement. And so we found that to be very effective, particularly with our little governance structure when we name names and work collaboratively together. So I appreciate you giving me some time, Art. Please chime in with your perspective and what your experience has been at Mountain Family Health Centers under this model.
Thank you, Patrick. Hello, everyone. Thank you for inviting me and obviously Patrick to participate in this. My perspective is I think in the intro and both what Patrick said, it's very apparent that what we feel needs to happen is, of course, the integration of all facets that Patrick mentioned, the data, the leadership, the financial, the clinical, and clear transparency. Rocky Mountain has been a great partner to us and allowed us 4 to 5 years ago to transform how we deliver care from a focused widget count, if you will, having to meet that magic number every single day and month to apply our PPS rate to meet our budget, to shift to a more value-based over that period of time and to shift our operations. That has been, I would say, an arduous task because most CHCs don't work in that environment. We're not geared to case manage. We're not geared to provide care based on population health in the reality of the whole spectrum of delivery of care. The team-based care model, incorporating medical, dental, behavioral health, utilizing support services like care coordinators or case managers, social health workers, outside entities that could help us. We've sort of developed that model moving forward over the last 4 or 5 years, and having Rocky Mountain as a partner has allowed us through this per member per month model to achieve and move and transition our operations there. It's been difficult. Traditionally, again, providers practice in a certain setting, in a certain manner, and we've all been used to that setting at CHCs. And it's definitely a difficult transition to move into a risk-based environment where you're risk stratifying your patients, you're moving into more collaborative care model integrated with all disciplines, and really taking a look at the highest, I guess, acuity or risk patients and focusing attentions and all the entities within your organization that you have to support that patient's treatment and case management plan. In addition, it's been a difficult transition to get us to a, I guess, collaborative model where we expand beyond the realm of provider, PCP, patient encounter, the face-to-face, expand to nursing visits, case management visits, social health advocates visits, interactions, bringing in patients to do nursing visits so we don't have to involve the provider when we're talking about lab results, talking about drawing labs, giving them feedback on how they're doing in their treatment plan. That's traditionally been a face-to-face model because we've been geared up to make sure we have that widget hit, that PPS rate encounter to get our FQ rate. That is no longer a transition. We've moved into probably about a 75 to 80% value-based delivery model here at Mountain Family, and we've also transformed our federal dollars, or are in the process of transforming our federal dollars to that PM per member per month, and sort of incorporating that into how we deliver care for our total population. It's been difficult. It's been a arduous transition, but I think at this point for this year, 2019, we've kind of gone over that hurdle, and we are participating, actually. I don't know if it was mentioned or not, but we're one of 3 CHCs that are participating in the, I guess, APM2 for Colorado, where we will be engaged in a PM model per member per month effective October 1st. So we have 1 month to go to shift our delivery payment model, if you will. And we've been working through this again for probably about 4 to 5 years with Rocky and with our local primary care association. So I will pause and see if anybody might have any questions for myself or even Patrick.
I want to thank everybody who submitted questions. We are going to take additional questions at the end of the presentations as part of our moderated discussion. But in the meantime, let me just take one question here, and I'll direct it to both Patrick and Art, and it's related to timing. Actually, I'm combining 2 questions. The first is, how long did it take for you to develop the model in Colorado, and how many months do you think it took for both the FQHC and the health plan to achieve the benefits of the partnership? Patrick, do you want to start off?
Sorry, I was on mute. Sorry. Yep. Hey, I'll be fast. So really, the timeline here started in 2013, looking ahead to Medicaid expansion. PRIME was an acronym, Payment Reform Initiative for Medicaid Expansion at the time. And we just recognized we needed a smarter payment model to contend with the requirements of Medicaid expansion. We built on work that we've been doing informally and put that structure in place under a statutory provision in Colorado in 2014. The payment model has really been the same, the core data sharing model. I would say over the last 4 to 5 years, the big news is that it's just been optimized. There's been a learning curve, as Art mentioned, for practices, certainly a learning curve for the plan about what the right level of support is. The tiering program went in about 2 years ago, and then the big thing was the behavioral health carve-out ending. Fortunately, because of the work, we were ready for that. That carve-out ended in July or in June of 18. We picked it up on our plan. with this new model. But I got to tell you, it took a lot of runway and a lot of meeting. What I would tell you also is we did it at the local level. We did it as plans and providers. The state became supportive once we got a statute through, which we advocated for to permit this model and really garner support for it. But we did the work ourselves, and now, as Art mentioned, the state is following through with a formal APM for the statewide program for areas that Rocky doesn't serve and populations that are still under fee-for-service. And so we're pleased, but it took a long time. It took a lot of work.
Great, thank you, Patrick, for that, and thanks to both of you, Patrick and Art, for the presentation. We're gonna move on to our next presentation, and I'll just remind folks that we do have a moderated discussion scheduled following the presentations, and we will try to address your questions there. So, turning now to California, I'd like to introduce Kurt Hubler, who's going to provide an overview of Inland Empire Health Plan's Shared Savings Initiative, as well as discuss why advancing VBP arrangements with FQHCs is important for health plans. So Kurt Hubler is the Chief Network Officer at Inland Empire Health Plan. Mr. Hubler leads the organization's strategy for provider contracting and administration, including hospitals, IPAs, and individual direct providers. He has 25 years of experience in contracting, credentialing, provider services, and health plan operations. Prior to IEHP, he was Executive Director of Medicare at CalOptima, where he launched and managed all aspects of the organization's Medicare Advantage Special Needs Plan, from sales, marketing, provider network management, and contracting, among other responsibilities. Mr. Hubler also has significant hospital and medical group experience, which involved nursing home administration, acute hospital administration, and medical group management. And we're grateful to Kurt for spending time with us today, and I'm going to turn it over to him now for the presentation.
Thank you. I'm just going to give a quick overview of IEHP and then get into our shared savings program. So IEHP, we cover Riverside and San Bernardino counties in California. We're a county-sponsored government agency, and our board consists of 2 county supervisors from each county, and then 3 community representatives, and we have an annual revenue of $4.5 billion. Our network is really a mixed model. We have 16 IPAs. About half of them cover our Medi-Cal network, and the other half participate in our Medicare network. And then we have IHP Direct, which is almost half of our enrollment is in IHP Direct, and that's where we contract directly with physicians, ancillaries, and hospitals, and any type of facility. So in our 2 counties, we have 1.2 Medi-Cal lives, and in our Medicare programs called Cal MediConnect, we have 28,000 enrollees. This is a report provided by the California Department of Healthcare Services, and it looks at all the Medi-Cal plans and ranks them according to their HEDIS scores. And there you see our red arrow. We're in the middle of the pack. So we hope to improve on that. On the left side, those are predominantly, Kaiser and other staff model facilities that have, physicians on a similar EMR and employed physicians, so they have much more control. So our network is very spread out. We have a lot of onesie-twosie doctors' offices, multiple EMRs, and so there's a lot more coordination that needs to be done. Of course, in California, Medi-Cal spending keeps on increasing about 10%, so we're trying to control the costs. Right now, Medi-Cal spends $82 billion a year just on Medi-Cal. So on value-based care, we're, of course, looking to align incentives with providers and payers and reward them for quality as well as pay them sufficiently. And then aligning the interests of patients and providers by increasing provider accountability for the full spectrum of care, which is why we started our shared savings program. When we looked at our value-driven strategies, they're really in 3 buckets: enhancing data analytics to our providers, population health management, and then quality and costs, providing value. And that's the bucket that we're really going to focus on today in our shared savings program. So our shared savings program is in our IEHP Direct network, and in IEHP Direct, we have 600 PCPs that get a primary care capitation and basically have no incentive to look at their continuum of care. Basically, while the capitation provides some good incentives, there are also some not so good incentives, such as I want to refer it out to the specialist and no real concern about the member outside of their PCP practice. So our goal in developing the shared savings program is to get them engaged into the whole continuum of care, and that they're looking at the big picture and not just their PCP practice. This is how we set up our shared savings framework. We develop a budget target, which is based on the previous year's PMPM, looking at historical claims, and we eliminate the top 1% outliers because we don't want the budget to be skewed one way or another. Then during the performance year, we look at their actual performance, and then we compare it to the budget. It's risk adjusted, comparing the performance year to the budget year, and then we also add an inflation factor. Then there's the shared savings, which they have the potential to get 60% of the shared savings. The cap on the potential gains is $4.50 PMPM, which doesn't sound like much, but don't forget these providers are getting a PCP cap of anywhere from, mainly $13 to $15 PMPM, so additional $4.50 is substantial. In order to get the participate in the shared savings, they have to at least have a minimum savings of 1%. And we're going to talk about the quality measures. Okay. So I'm going to go back. I think we're missing a slide. So we have quality measures. Those are the quality measures. It's the all-cause readmissions, controlling high blood pressure, the C-section birth, breastfeeding intent, and post-discharge. Each of these measures get a potential of 3 points for each of the 3 measures. And to get 1 point, they just have to achieve the same score as they did last year. 2 points would be a 10% improvement, and 3 points would be hitting the 75th percentile. So they have a potential, of course, to get 15 quality points. And then that impacts what their shared savings is. So, for instance, 5 points gives them an extra 10%. So they start off at $40 PMPM, 40% of the shared savings they could obtain. And then if they hit 5 points on these quality measures, they would get 44%. So the more quality points they get, the more it impacts the percentage of their shared savings that they're going to obtain. So we implemented this in 5 different groups. And here you can see 2 of them are FQHCs, and this is only on adult members. We eliminated the pediatric members, mainly because a lot of the high utilizing pediatrics are in the California Children's Services program, and that picks up the cost of that. So, and then there's low utilization for those that aren't being impacted by CCS. And so we decided to implement this just on adult members over 21. So there you see the participants in our first FQHC has 10,000 lives. Arrowhead Regional Medical Center is the county system for San Bernardino. It's not an FQHC, and they have roughly 43,000 members in this program. Riverside University Health System is an FQHC. There are other county system in Riverside, and they have 55,000 shared savings. RFP is just a multi-practice physician that has 5,000 shared savings members that wanted to participate in this program. And then we work with a group out of Providence, St. Joseph's Health System, and they have 9,000 shared savings members. So to make the following investment support services, this isn't a type of program where you just set up the contract and walk away and hope for the best. We have very intensive interactions with these programs on a monthly basis in various groups, and we have a number of subcommittees. So we help to develop their infrastructure, their operational infrastructure, and how they could work to improve and control costs and improve quality. And there's a significant commitment of time and energy from really a number of people throughout the health plan, including pharmacy, our informatics, our IT, provider services, are all involved in working with these groups, very much a hands-on process. This is just, I wanted to give you a flavor of the reports that we provide them to help them manage their costs, and also a lot of what Rocky Mountain does in comparing to our network as a whole, how they perform against our network. But they get a lot of reports that and this is part of what we go through in the different subcommittees and the leadership committees, is looking at the results. And this is a data package that's provided for them on a quarterly basis. So when we set out to work with these groups, we actually had a consultant come in and work and do an analysis of the various participating clinics and identify where they are, their current state, and look at the gaps and what we need to work on and focus on in order to really, improve the quality and control the cost. So these are, just some of the sections that we have. Data connectivity integration, how are they connected with our HIE in the area and getting information, and is it integrated into their EMR? Data and reporting is a lot what was shown in the prior slide. What is their member empanelment system and what's appropriate for that clinic? Looking at hospital partnerships and transitions of care, how they work with patients admitting to the right hospitals, and also how are they transitioning the member out of the hospital. Population health strategies, working on care management activities. Every group has a pharmacy subgroup that works with the group on how they could really utilize our formulary and really what's appropriate, the expertise from the pharmacist, and working with the group on ways that they could reduce the pharmacy cost. In addition to this program, we have other P4P programs for the physicians, and so while we're in there working on the shared savings program, we also look at the results from our typical P4P program that continues to go on underlying this program. And then, of course, we set up the various leadership meetings. Usually the leadership meeting meets once every other month, but then the subcommittee meetings are meeting more often and report into the leadership meeting on the status. So then the question of when did this start, really started looking at this in 2016, developing the program. St. Mary's actually started pretty much in January of 2018. They were our first program to be involved in this program, the first medical group to be involved in this program, and then the other groups came on in January of this year. So each of them have an individual assessment, like I said, and we look at their gaps, and it's really a program tailored to each group to see how they could impact the whole quality of care for the members. So that is our shared savings program, and I guess we're taking questions at the end.
Thank you, Kurt, for that presentation. We're actually going to jump right into the moderated question and answer. We have a lot of questions coming in from folks online. We appreciate that. I invite you to continue to submit questions. I now want to turn it over to our moderator, Tricia McGinnis, who is Executive Vice President and Chief Program Officer here at CHCS, and she will be moderating the next part of the presentation.
Great. Thanks, Greg, and thanks, Kurt, Patrick, and Art. So we've gotten a lot of great questions over the chat box, which is always exciting to see. So to kick it off, we'll go to the first logical places, which is around how you all got started with this work. So to Patrick and Kurt, curious about how you selected the FQHCs that you wanted to work with initially. Was there certain criteria that you used to establish a partnership? How did you go about thinking about which FQHC contracting partners would be the right ones to move in this space with?
Hey, this is Patrick. So for our plan, really it was an inclusive process. We didn't rule anybody in or rule anybody out. We really just focused on what the payment model would be, what the contractual expectations would be. And so, again, they had to adopt they had to be willing to adopt a non-fee-for-service model. They had to be willing to engage in our practice transformation program. They understood what quality targets would be and what the incentive opportunities would be. We did that really for a couple of years until we had a much more formal tiering structure. But in essence, we admitted everybody, adjusted payment and resources according to engagement and competency, and then really formalized that now with this 4-tier structure we have.
For IEHP, it was very much picking a special group and having criteria. So it actually started with Providence St. Mary's coming to us and wanting to look at a unique relationship. And so at the time we called it the Total Cost of Care Program. So it started with them, and then we decided that we wanted to expand this into our other larger medical groups. And what we're looking for actually is health systems where you have a medical group aligned closely with a hospital system. We didn't want it where they were a standalone, which is why you see on some of the quality measures there are things that are aligned very much with the hospital and not so much with the medical group, such as breastfeeding and cesareans. So our two county systems, of course, make sense because, as an independent medical group, they have a large enrollment, and then the other FQHC, SAC, is highly connected with Loma Linda University Medical Center, a tertiary hospital in this area. And then we had a unique, the last one with only 5,000 members is a independent physician that wanted to see how he's very much involved. He's a patient-centered medical home accredited and is very much into the whole practice of continuum of care, and actually came to us and wanted to work with his group on and really looking at all aspects of the care that's delivered to the members that are assigned to his clinic. So he's always a forward-thinking physician, and so we decided to work with him. Really, and the other thing is we have a minimum requirement that you have to have at least 5,000 adult members that would participate in this program.
Great. That's really helpful to hear the different approaches you all have used to identify your partners. Building off a point that you were making, Kurt, could you tell us a little bit about both Patrick and Kurt, how in your role as health plans, what role, if any, you've played in really helping the FQHCs build partnerships with other providers, such as hospitals, behavioral health specialists, other specialists? Has there been a role that the health plan has played in helping foster those partnerships or connections?
I'll go first this time. So in each of these groups, we have embedded a health homes team, which is a grant program through the state and federal funding. And there's specific criteria for members that are involved in the health homes program, but it's a multidisciplinary group that includes an RN, a behavioral health therapist, a community health worker. But you get the flavor that it's multidisciplinary care management approach, and we actually located a team of these people into their clinics so that they're on site. They could actually see the members face to face when they come into the clinic, as well as do telephone outreach. So it's not just work from the health plan and call people. We do that in other practices, of course, where the physicians don't have the large number of member enrollment. But in these practices where there's a good number of enrollment, we embed the care management team right in the clinic. And as I said, a lot of these groups, I said, are connected very much with the hospital system. And so a lot of their concern is, why are so many of their patients going to outlying hospitals? Some of it makes sense geographically, but it's developing a relationship. We work with them to connect with the hospitals, work with our hospitalists that we contract with in each of the hospitals, so that they have a relationship with those hospitalists. And actually, a lot of the groups are very concerned about having their members come into their hospital as much as possible, but the ones that don't, they want to work on with our contracted hospitals on, what is the status of this member, when are they being discharged, and how can we follow up and get them into the clinic post-discharge. So those are some of the things that we're doing.
Very quickly, I would say it's similar. Our biggest boots on the ground workforce is our practice transformation team, really engaged in transformation, QI, and data use competencies. We also deploy what we call community care teams. Sometimes those are just housed directly by the FQ or the partner. Mountain Family holds contracts for and hires a large community care team. We don't really embed folks. We contract and hold the provider partner accountable for care management requirements. Same is true with behavioral health. We don't embed behavioral health. We will, as I mentioned earlier, offer kind of an incentive contract in which a top tier practice can hire their own behavioral health clinicians and put them on the same record, and as long as they perform, we sustain that. The plan does all sorts of things, of course, you'd expect a health plan to do with respect to care management, care coordination. But I think the difference is that we have less of an embedding arrangement and more of a kind of a contracting arrangement. Our biggest workforce is really kind of practice facing around QI and transformation.
Great, and I'm curious, digging into that, your answers a little bit, how much have those resources and supports that you've provided, are those consistent with supports that you're providing to other practices, or are there things that really are unique that you're providing to the FQHCs that you're finding are very different from other supports that you may be providing to other types of providers, like other primary care providers, for example, or is it pretty consistent?
On our health. Go ahead, Patrick.
Sorry about that. It varies. Generally speaking, FQs are very well situated to support this strategy when they can. When they're successful, we invest heavily in them. We have a very large care coordination contract with Mountain Family, but that's not the same across all FQs. Some of them are just in better position to do more. In other cases, those resources go to private practices, community-based programs, or just stay with the plan, trying to cover all of our geography. The short answer is it varies really according to performance and capacity.
Yeah. And Kurt, what are your thoughts on that question?
In our Health Homes program, as far as embedding them into the clinic, we do that with some other groups, but only ones with large enrollment. So the other ones are pretty much telephonic, regionally, even though we have regional centers, because we have a very large geographic area, even though we're only in 2 counties. You could drive north to south 2 hours it would take you, and east to west would take you an hour and a half. So a large geographic area, and so we do have rural centers with a Health Homes team. But the thing about, unfortunately for the programs, like I told you, we had 1.2 million members, and you can see we have a scattering of lives in this program, so this is really more a pilot to see the impact we could have. But the rest of them really don't have the incentive. They're pretty much just focusing on their PCP cap and don't worry about things outside of their cap, which is obviously the mentality that we want to change. So that's the biggest difference.
Right.
Is there's no incentives for the other ones to care about what's happening beyond their PCP practice.
Thank you. So thinking a little bit internally about what it takes for health plans to enter into these type of arrangements, I'm hoping that you all could share what it took for your organizations internally and operationally to get ready to implement these VBP arrangements with the FQHCs.
You want me to go first? I'll go first. You can see from our timeline, it really started in 2016, and we, in order to assist in developing this program, we engaged an outside consultant to work with us. And really the first year was just developing, getting everybody on the same page internally and where we wanted to go with this program and how it should be structured and what we should motivate, because we already had P4P programs, so we didn't want to just duplicate those. And then it took the time. We had some initial meetings, but then it took the time to actually go out and then do the clinical assessments, which was probably another 6 months. So honestly, I'd say it was an 18-month process between when we had our initial meeting to January of this year when we brought up all 5 of the groups, even though we had St. Mary's going a year earlier. But their program was modified as we developed the program internally.
Yeah. This is Patrick. I'd say it's the same timeline, a year and a half to 2 years worth of lead time. Ours was earlier on, kind of in advance of the Medicaid expansion in Colorado. We went live and then we worked really hard to optimize. The hard thing for the plan, of course, is being committed to this new model, making these APMs work on a machine and a platform that is really built for fee-for-service. And we just had to continually work inside the plan to come back to attribution versus assignment, make sure risk adjustment was working, make sure that our payments were accurate, make sure that we had the reports in place to ensure that the APMs were performing as they were supposed to perform, better than fee-for-service. That took a culture change and just a commitment inside the health plan operations to make that happen.
Great. Pivoting on one topic that's come up a few times in the chat box around data collection. Both of your organizations are doing a lot in terms of providing data to the FQHCs on performance to support their work. And I'd love to hear both of you share what some of the biggest challenges have been for you to gather that data and how ways that you've approached overcoming those challenges.
I think there's 2 different parts of the data. There's, that slide that I had that showed all the data reports, and those are good, but, you got a realistically 120-day lag because you're working off of claims and things like that. I think what's more important is our data integration activities that we're doing. And what we're doing is we're connecting the medical group with the HIE that we have in the area. That is, we have an HIE that's connected to 30. We have all our contracted hospitals, a large number of physician groups. And so they're getting, ADT discharge, admit discharge information on a timely basis rather than having to, get some report later on. And then we integrate their HIE right into their EMR so that they don't have to go outside of their EMR in order to get the information. So the data reports are good, and probably you could put out any data report that they request. But what's more important is getting them the timely information of patients that are in care right away outside of their health system that they're not tracking or going to another ER, and getting that information on it comes to them with a 2-minute delay from the HIE. So that's been the most significant data impact.
I would echo that 100%. I can't underscore how important and valuable HIE is. We actively promote HIE HIE participation, have used every lever we could pull to pull hospitals in to our local HIE, and actually to help build a statewide network across the 2 major HIEs in Colorado. That's a game changer. The clinical data and registry focus, the alignment there is that the plan was Rocky was able to get the state to allow us to move off of HEDIS for several critical measures to ECQM measures, kind of adopting and modifying ACO type targets for clinical data. That made sure that the plan, the state, and the providers were all aligned on the specific measure targets. We didn't have any gaps around admin versus clinical on HEDIS. That was huge. And then in terms of collecting that data, the providers collaborated in reporting. We had a workforce on the ground, as I mentioned, our QI kind of facing workforce that would help and monitor EHR dashboards, make sure we're getting accurate information. And all in all, there's got to be clinical data integration, and health information exchange is a game changer when it comes to transitions and care management.
Those details are really, really helpful from you both. A related question, I'm assuming probably comes from an FQHC in the audience or just another provider, and that's, a lot of providers aren't necessarily working with plans that are as innovative around data sharing as you all are. What advice, if any, would you give to providers to help them make the case to their health plans around data sharing, particularly around claims and cost? Any advice that you would give to folks in the audience around that?
Go ahead, Patrick.
Thanks for that one. What can I say? All the stuff that I'll just be blunt, all the stuff that health plans complain about, worry about, all of the abrasion that happens between providers, just even around old school QI things where you're trying to like close gaps on data that's old. You're trying to do things that are kind of antiquated. That doesn't change unless you change, and it doesn't change unless you're willing to. But my advocacy was mostly inside the plan to try new things. And, once you get over that hurdle, then you find yourself in this partnership that maybe feels a little bit uncomfortable at first because you're sharing a lot of information. You're spending a ton of time on stuff, and there's all sorts of one-offs, but it makes it easier, and then it plays out in the data. Again, how does the health plan beat the state's, let's say Medicaid managed care, beat the state's requirement? We have a hardcore requirement in Colorado that we have to be budget neutral to fee for service, and then the current administration put a savings requirement on top, a 2% savings requirement. We got to pay for all of our admin, all of our APMs, all of our everything within something that's less than 2% of fee for service. You just can't do that, I think, at this point in time, unless you're actively working on data sharing and VBP type arrangements. So unfortunately, we can do it. It's working. We sustain enhanced reimbursement, cover our costs, and save the state taxpayer dollars. The state's own actuary reported that out this year. So but you have to work together to do it.
I guess we have a positive example that St. Mary's Providence originally came to us to initiate the program. So that's an example of a medical group stepping forward and coming to a health plan and saying, we need to do better. And hopefully you have someone listening with as an open-minded person. And, this is so much in the industry now that I can't believe that there are a lot of plans that wouldn't be getting into some aspect of this.
Great. Thanks for taking that tough question. Here's one that I think will be relatively straightforward, and that's how did you all approach and go about selecting the quality measures for your models?
Ours was less is more. Instead of having 32 or 64 ACO or EHR measures, we kept it to 4 or 5 or 6. The average practice can't focus or doesn't really care about more than that. We tried to get an alignment. They gave the practices and the FQs insight. Then we had to negotiate with the state to make sure that we were aligned. The state always has its own desires and fixations and fancies about where it wants to go with quality. And so we really had to work hard to narrow and align. Right now, we've got an SUD domain, a patient activation domain, diabetes and comorbidity, and some of the things you'd expect, but it's a really narrow set of measures. And the big thing was getting off of HEDIS and getting onto CQM so that we were completely in alignment with what we were asking the practices to do.
We have a very substantial pay-for-performance program already established with the PCPs and our IPAs and also our hospitals. And if you want to look at those, they're on our website at IEHP.org. But what we didn't want to do is duplicate just what they're already getting incentivized for in their already established P4P programs. So that's why we diversified some, basing it on readmissions, the cesarean birth rate, breastfeeding. Some of it does overlap on the high blood pressure control, but doing also the 7-day follow-up. So we were looking for something unique that they're not already incentivized for and that will move the needle on cost as well.
Great. And from a broader perspective, how are each of you measuring or assessing whether these initiatives are successful? What sort of overall measures or metrics are you looking at to gauge the success of these initiatives?
Ours is simple because we have the, at the end, we compare the baseline program, the baseline period to the performance period. And so you could see how they did on a cost basis with the adjustments for risk adjustment and also an inflation factor. And then on the quality, and then of course you have the quality measures that you're scoring, the 5 of them. So, but as I also said, we also, since we're working with the group so closely, we also work on, we include in our reporting and discussions how they're doing in our standard P4P program as well. So all those are quantifiable, and we track the performance level and year-to-year improvement.
I would say the same. The bottom line is that we have to, if we want to do APMs, we have to afford to pay for them. Yes, the enhancements that go out for some of the top tier providers are significant above the fee schedule or the state fee schedule equivalent. And so that only works if the plan performs. We know every year, every quarter, whether or not we're performing, and that's the starting point. But, growing attribution, moving practices up the tiering structure, really getting past benchmarks on quality performance. Those are the simple measures of performance, and we feel good when we see that more of the membership is being served in the higher tier practices, and we see that the higher tier practices are meeting or beating the network benchmark. Those are the kinds of things we need to see every year for this to continue.
Great. So two technical questions for you both. So one, I think it'd be helpful for the audience to understand, Patrick, you made an important point around attribution versus auto assignment. And so if you could just, one, clarify the distinction between the two for the audience, but then two, talk a little bit about how you were able to make that shift from an assignment perspective to an attribution, and kind of operationally what you've needed to do to really deploy an attribution-based model. Yeah.
Well, they're both tools, and we've emphasized attribution quite a bit over auto assignment. Auto assignment still has a role in managed care. The issue, though, is that for years, the programs are built on auto assignment, and you end up making assignments and making payments and doing measures on people that actually don't use the system of care. And so we wanted to change that by using an attribution method that showed there was a current, active, real relationship there, one way or the other. create incentives for people to, instead of just saying, here's your assignment list, go out and get them. Or my favorite story is that we put out the assignment list and the providers say, well, why is this person on my list? I don't know who this person is. Well, of course you don't. You're not using your care. They're not using your system. Now we have attribution, and the question is, why isn't this person on my list? That's a more productive conversation. We actually have data we can show about why they're not on the list, and answering that question improves the data quality. So the whole point of attribution, it's a pain in the neck in many of its own ways, but at least we're paying for a recognizable, active relationship, not just kind of a old school assignment of membership to a group of providers.
Great. So another important kind of technical question. Wondering if either of your organizations has spent time working with FQHCs around billing and coding practices as they pertain to the VBP arrangement. Has that been something that you've found has been necessary as part of your work with FQHCs?
Yeah, Art, you resemble those remarks, don't you, in terms of our coding and diagnostic and risk adjustment efforts? Do you want to share a little bit about what you guys have had to do?
Patrick, I believe Art had, I think Art had to hop off. Yeah. Okay.
Yeah. Well, the short answer is that, accurate coding and diagnostic coding for risk adjustment is a big deal. That is not part of the typical PPS or any fee-for-service world. And so we've had to invest heavily in helping practices code better. It's a burden, but we in the practice can better recognize complexity and adjust the payment so that the payment follows the work. And but I would say it's a heavy lift and not something the average FQ in particular has had to deal with much outside of capitated programs. So.
On our medical program, I'd say it's one area that we could probably do improvement on, especially with the county hospitals. We find that their coding, they're not used to being worried about coding at all for billing or anything, and so they've needed to come a long way in coding. And obviously we risk adjust, which is based on the coding, so we'd like it to be accurate, but we don't really have an outreach to try to improve their coding on the Medi-Cal side. Now, all of these people participate in our Medicare program, where obviously their coding is extremely important for your payment to make sure you're getting paid for the work that you're doing. So, we have coders that go out and meet one-on-one with the doctors, review their records and documentation and see how it compares to their coding. So those efforts are hopefully that we're doing on the Medicare side will transfer over to those same doctors that are working on the Medi-Cal side. But really our coding efforts are really focused on our Medicare program.
Got it. So turning to the important topic of social determinants of health, we have a few questions from the audience on that. And I'm going to broaden these a little bit just to understand from you both how do social determinants of health fit into these models? Are there any components that you're working with the FQHCs around? Have you heard of your FQHCs partnering with community-based organizations around social determinants as a result of these arrangements? Just curious about how that piece fits in within your work.
In the Inland Empire, so obviously social determinants are very important. We actually created our own website for all the physicians to access. It's on the web, and it's called IE Connect, and allows the medical groups to really identify resources, whether it's housing or food or social service agencies, a really comprehensive look at all the agencies within our service area that are available, faith-based agencies too, for support that the physicians have access to. So we do a lot of outreach for them to work on that IE Connect, and also obviously survey their members when they come in to actually do a social determinants of health survey to see. It's called the ESPERT form, to actually identify needs that a member has outside of their direct health care needs. So if you want, IE Connect is on the website. You can look at that, and you can take a look at that to see how it works and how it's laid out.
Great. Thanks, Kurt. Patrick?
Social determinants is a huge focus area. It's kind of what I think about behavioral health 10 years ago. We're very actively promoting social risk factor screening. We're participating in a federal cooperative agreement, the Accountable Health Communities model, to help support that and move it along. FQs have, I think, nationally been engaged in the adoption of the PREPARE tool, which is a pretty widely recognized social risk factor screen. So in essence, it's a couple of components: promoting screening and awareness across practices, beginning to develop incentives and supports for screening, procuring a network of food, housing, and other community-based providers. That's new territory for us. Not just simply throwing out a resource network or a book, but actually actively kind of putting a network together, building partnerships with those organizations. The last piece is building on the health information exchange in our area to bridge social and health domains. And the group in our area, which is called Quality Health Network, is rolling out this thing called the Community Resource Network, which is its social information exchange. They'll leverage several of the technologies they already have to support things like alerts, task and record sharing, consent management, so that health and social behavioral groups can share information better. Very complicated, as you might imagine, but we're very much focused on that. I would say that, hopefully 10 years from now, we'll be as far along with social determinants integration as we are with behavioral health integration. So many of the behavioral and health drivers are socially based, as we all know, and that's where we need to be investing our energy and time going forward.
Great, thank you. And that's actually, Patrick, the perfect segue to the last question for you both. And that's just, what's next? What's the next iteration of these initiatives? How are you thinking about building on them and expanding them in the coming years?
I'll go first. So we have our, obviously this only touches, a very small segment of our membership. So I would say our IPA contracts need to be restructured. I'm talking about the Medi-Cal side, not so much the Medicare side. Basically, our IPAs on the Medi-Cal side, they get paid their capitation for the standard outpatient facility services, professional services, ancillaries. But we're behind the times in our IPA contracting because we don't even have an incentive pool for them to participate in. So much like our PCPs, where they only get their PCP cap, our IPAs just get their IPA cap, and they don't look at things. I work with them every day about, they need to contract with our hospitalists. Sometimes they just look for hospitalists that are cheapest because they pay for the professional fees and they're not really concerned about the bed days or the quality of the hospitalists. And those are things that we have to work with them on a regular basis because they aren't really concerned about the overall impact of the member outside of what they're capitated for. So we have to change that concept altogether. And then probably we need to, on the other aspect is that we need to share it, expand the shared savings programs to some more of our larger groups in our direct network. And we're also looking at possibly doing risk adjustment with our PCPs. Right now they get a standard cap based on aid code and paying them based on their risk adjustment score with the members, which of course would give them incentives to look at their coding and also submit their encounters and things like that.
Yeah, this is Patrick. I would agree. We need to kind of modernize our IPA arrangements. They've come on board, and we've generally been able to put this model in across all of our lines of business: individual, commercial, Medicare, and Medicaid. But we kind of need to move from what I think of as APM, which is at the end of the day, a payment model, to modernized partnerships, whether it's with the hospitals or the broader IPAs, that can really drive system change. Right now we're making a difference for primary care and behavioral health with the things that we're doing, but there's a world of broader risk sharing, ACO and bundled payment type arrangements we could take advantage of if we could just kind of modernize some of the structure in our region. And we have some levers to do that, but that's our next step. And of course, beyond that kind of age-old quest, going back to behavioral integration, clinical integration, and much better focus on social risk factors as a predictor of healthcare spend. We can do that certainly with primary care and behavioral health, but getting IPA and hospital engagement in that effort will be very important as well going forward.
All right, thank you. And thank you, Tricia, for moderating that discussion. And I just want to remind everybody, now that we've come to the end of the program, to please complete your survey. Your feedback is very important to us. And I just want to end by thanking all of our presenters who shared with us today. I want to thank the California Healthcare Foundation and Blue Shield of California Foundation for making this webinar possible. And of course, I want to thank all of you who took the time to join in the conversation today. And we are adjourned.